Without further ado, I can see we're right on 2 o'clock. Let's be prompt, shall we? Welcome so much to this webinar on pain and activity. Where today what we're going to do is explore some of the new research that studies why increasing how much we move might actually be so challenging. So my name, if you've not met me before, I'm Tasha Stanton, and I work as an associate professor at the University of South Australia. And I also lead the Persistent Pain Research Group here at South Australia Health and Medical Research Institute, also called SAHMRI, or the Cheese Grater here in Adelaide. And this webinar is brought by our group today. So before we begin, I would first like to acknowledge that I'm hosting this webinar from the traditional lands of the Kaurna people, and that we respect their spiritual relationship with the country. We acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I'd also like to recognize the traditional owners of the locations where you all work and live today, and the First Nations people present in this webinar. We pay our respects to elders, past, present, and emerging, and we celebrate the diversity of Aborigine and Torres Strait Islander people and their cultures and their connections to the lands and waters of Australia. Now, friends, you are all in for a treat today. We have just an excellent lineup of 4 speakers that are just doing really interesting and novel work in the area of pain that holds relevance to movement. And all of this stuff, guys, it's hot off the press. This is new findings that are just coming out now, so you're getting the first peek. What I'd like you to do, just to orient you to this, the webinar itself, please use the Q&A box at the bottom of your screen to place any questions that you might have for the speakers. And we will have all the speakers complete their talks first, and then what we'll do is have a joint Q&A at the end. So if you do have a specific question for a specific speaker, if you want to put their name in that question, that would be great. Otherwise, I might ask it generally, which is all good too. So without further ado, I'm very excited to introduce our first speaker of our webinar event, and that is Dr. Carolyn Berryman. Carolyn is an adjunct research fellow at the Brain Stimulation, Imaging and Cognition Group at the University of Adelaide and SAHMRI, as well as she's a senior physiotherapist at the Women's and Children's Hospital here in Adelaide. Carolyn is the jack of all trades. She can do anything. She has a multidisciplinary pain sciences approach to the treatment of and teaching about musculoskeletal conditions. So she has over 20 years of experience as a clinician, managing a private practice physiotherapy clinic, as well as spending over 20 years lecturing and tutoring on the physiotherapy program at the University of South Australia. So she is well versed in this area. She has done very well in research. She was awarded an NHMRC Early Career Fellowship. It's a pretty big deal. And she was investigating brain plasticity and its contribution to recovery in people with chronic pain. And today, she's going to talk to us about, have you got pain? Then I've got movement. Please go right ahead, Carolyn.
Thanks a lot, Tash. I will just share my screen. Hopefully it'll work. Of course not. Here we go. Okay, can people see that? Is it all, yep, visible? Great. So thanks very much for having me and organising this, Ola, and hopefully we'll get through some interesting information to you today. Mine is actually regarding adolescent pain and an adolescent pain project that I've just been completing. And so the title of the talk is If You've Got Pain, Then I've Got Movement, and why it's important to get moving before pain goes and how to get there from here. I'll also give you just an acknowledgement of country. My feet are resting on Kaurna land today, and I'd like to begin by acknowledging the traditional owners of the land and recognise the important spiritual connections to the land and water on which I work today. So I'd also like to pay my respects to elders past and present. And the only reason that I'm doing this, well, no, there are many reasons, but I'd like to show you Adelaide. And so this is where we have been, or this is where the webinar is coming from. And these are the autumn colours, which we've just finished in Adelaide. So here's a roadmap of my brief talk to you this afternoon. So chronic pain in adolescence, we're going to have a look at whether that's a thing, why move, what stops moving, and how to get moving. So chronic pain affects 1 in 5 adolescents, and that's a very recent sort of systematic review. It's a worldwide figure that's taken for the truth, being out there. We actually in South Australia don't have a great deal of prevalence data, and hopefully that's going to change because we're doing a couple of projects that will look at the prevalence of chronic pain in adolescents, but we think it'll probably come in around 1 in 5. Most commonly, it's abdominal pain or functional gastrointestinal disorders, back pain or daily headache. There's evidence out there, actually taken quite a long time ago in 2012, that shows that adolescents with chronic pain have lower activity levels. And the risk factors to lower activity levels in adolescents include long-term vulnerability to anxiety. And as you can imagine, as we'll go through in just a minute, adolescence is a period of great anxiety. And so if you put that together as with chronic pain, then the vulnerability to actually stopping movement increases quite a lot. Parent and child orphalizing pain or catastrophizing pain. So if the parent, depending on how the parent responds to the pain, that also can cause anxiety and also stop movement. And negative pain memory bias. So how your parents, and the P in the brackets there is actually referring to parents, because how parents recall pain episodes really affects the way that adolescents respond to those episodes again in the future and become anxious perhaps about the episode recurring or the fact that they can't do something. So they become very anxious about movement because that would have been part of what had caused their pain, in inverted commas, beforehand. So memories about pain also can be a vulnerability factor to stopping movement. Interestingly enough, when we treat adolescents with chronic pain, the overarching goal is a coordinated interdisciplinary care for adolescents with chronic pain, and the primary goal is return of function. And we aim for that actually before we do anything about changing pain, and I'll explain that a little bit in a minute. So the relationship between the biopsychosocial factors and changes during adolescence in pain make it very make the difference between looking at adolescents with chronic pain and adults with chronic pain. They're not the same thing. So during the process of going through adolescence, there are a lot of changes that occur. As you might remember, if you go back to thinking about all the anxieties and the relationships and the social concerns that you had as an adolescent, and feelings are big as an adolescent. You can't put the stopper on those things, and things that wouldn't necessarily impinge upon you as an adult, you feel really in magnified form when you're an adolescent. And all of these things, the sort of changes that occur like in sex hormones and in brain structure and function, and the formation that you have of making your identity into an adult or identity, they're all put there. So you do grow through this being a child to being an adult. And often there's a lot of push and pull at that point. You want to be autonomous, you want to push yourself forwards, you want to have very good relationships with peers, you want to have conflict actually with your parents. And so you can imagine if you're trying to manage chronic pain in amongst that relationship, that when we do it, we need to look at the families as well as how the children and the adolescents are dealing with all of this, and everybody needs to be brought onto the same page. So usually when you have a coordinated care process in adolescents with chronic pain, it's across the board with families and peers, and we try and bring everyone along to the same page. So that includes the same page of movement. And so why functional restoration first? Why are we trying to get the kids to move before we even deal with what's happening with their pain? Well, engaging in sports and activities is one of the ways that you enhance cognitive and social development. And getting out there and playing a bit of soccer, or getting out with your peers and going for even just a walk around the park, they're all good for developing relationships and for developing modulation of the nervous system. So engaging in sports and activities will help descending inhibition. It will help to control the pain, even though we're not directing it at pain, because it actually improves other things as well. There's a biomechanical aspect to actually getting moving again, and that's recirculation of the immune cells with each increase in activity. Not moving means that your immune cells, they get a bit lazy, and they might just sit down by your feet, down the distal ends of your limbs, on the sides of the blood vessels, and they just sit there. They don't do anything. They're not being helpful. They're not being put back into circulation, and immunosenescence sort of sets in. That is not the optimal function for your immune system. So unless you're actually up and you change your blood pressure and you start getting some blood squirting through there to push them off the sides of the walls, then you tend to have a decreasing function of your immune system. And you might notice that actually when you see people with chronic pain or with adolescents with chronic pain, the less they move, the more often they complain of having colds or flus or being sick or not feeling very well. And so part of getting moving is really a biomechanical process of actually trying to get the immune cells recirculating. And regular activity mediates anti-inflammatory and antioxidant states as well. So there's a metabolic component to getting moving. And the immune system is also very fed on the metabolic state. So if you're not actually moving around, then your immune system is also not very well nourished. Improving sleep hygiene will be improved, certainly if you have regular movement. So one of the things that also changes in adolescence is sleep. And there's a lot of reasons that sleep changes in adolescence, but if it's because you can't get to sleep because of pain or you're not doing enough activity, you're not wearing yourself out enough, then there are some good reasons to actually get moving again, so you improve your sleep. A lot of the healing, a lot of the recovery that might happen within your body happens around about 3 o'clock in the morning when you get rid of all that lymph from your brain circuitry and change over the immune system then. So you want to be asleep and deeply asleep around 3 o'clock in the morning so that you actually have that nourishment and change in your immune system. And the last thing here is the ill-defined image of who you are. You might have been a person who really, really loves dance, and you might have got an injury and that might have gone on to impede your capacity to dance. And so when we're looking at people with chronic pain, adolescents with chronic pain, we also have to consider what it is, how they see themselves, what their identity is like, and see if we can find things that might actually take the space of perhaps being a dancer to being a something else. And the reason for that is that when you change behaviour, then you also adopt an identity. And so if it might be, I reckon I can say this about Tash, Tash would identify as being a runner. She's a runner. I'm a swimmer. That's what I say I am, because I always do that sort of thing. I've got an identity for that. When you lose that identity, then it's also a bit of a knock on trying to get back into doing something, because you haven't got that that hook into something that you love. So a lot of getting going with function is also about experimenting as a science sort of experiment, putting yourself there and going, well, okay, so would I like to get out there and run on the soccer field, or would I like to have a go at something like yoga? And often we'll start people off fairly gently with yoga or Pilates or some TheraBand exercises, but usually we just call it movement. We don't call them exercises, so that they know that they're going back into doing something that their peers would like. They would love to do all of this in a sort of normal environment. So trying to find community spots where they can actually try these things out, and it seems like it's a pretty normal thing to do with their friends. What might stop you from taking on this function? A decreased positive affect, as this cat appears to have, will certainly stop you. Like if you can't make rapport with the person and try and get them to just experiment with a few things, then this is going to be something that we need to address from a very practical sense. The effect of activity, we know though, is may not be as modulating on some people with ongoing chronic pain states. And that may be due to imbalance with descending inhibition. It could be due to hypersensitivity. It could be underlying processes which we can't identify yet. And this comes into juvenile fibromyalgia, for example, where we know that there are changes to the immune and the metabolic systems, but we don't know how to facilitate them in a way that we would normally do with function. You might not want to get out and work again because it hurts. So it's a matter of working through reconceptualizing what hurt actually means. And that might be trying to deal with the anxiety that it hurts, so I might be damaging myself more, or is hurt always equal to harm? And some of those beliefs and concepts that we might need to deal with. you might be busy with other commitments, and teenagers and, you know, adolescents with chronic pain, they're always got a very busy lifestyle. They've got lots of things to do. They've got to go from high school beginning to the end of high school. They've got people to meet, places to be, and things to do. And we would love it if they continue to do that. So part of our idea of increasing function is actually enabling them to be functional at school and places where they develop socially. And often I can tell you from the Women and Children's Hospital here that 5 days out of a fortnight, we would see people not going to school when they're in the midst of trying to deal with chronic pain. And so there are lots of ways of changing, and function in this instance would be discussing things with the teachers and bringing that sector on board to try and improve the way that pain is managed at school, so that they can also engage back with function and PE classes and things that will develop them and develop their identity as humans and adults. Uncoordinated and confusing remarks from medical professionals also don't facilitate return to function. And so we need to think carefully about how we deliver information. And one of the ways of doing that is actually thinking a little bit about probably motivational interviewing, probably a little hypnotic suggestion, but things like, that's it, you're doing it just right. Isn't it amazing how your body might cope with that? Isn't it amazing that your body actually says, I want to go and do that? And so feeding into the sort of natural ability that we have and want that we have to get back to movement. Same with the parental sort of concern and orphalizing. So there is trying to bring the parents onto the same page, those kind of messages that would explain pain to them and reconceptualize it. The other reason they might not want to take on function is it takes effort. And here are some ways of trying to make it seem like it's not taking quite as much effort. So very practical. What can we do to overcome these barriers? Well, make activity social and fun, make activity fit into life, and pace activity and make it achievable. So social and fun. So we've started using virtual reality with the kids here, and that is absolutely, I think you're going to hear more about that, but it's just, they've taken to it like ducks to water. And we've got a little study going on, which we can't give you the outcome for until next year, but it's adding virtual reality to physiotherapy treatment. And already we're seeing excellent benefits from that for getting people moving again. Trying to get this movement happening in a normal setting, and this is really important for adolescents. So trying to find a community setting or a yoga setting, you know, yoga or Pilates classes out in the community where they feel like they can take a friend and they can do something that's really social and appropriate for their age. So not sticking them in the yoga class that the 70-year-olds take or anything like that. So trying to find things that normalise movement and normalise activity. Work with the adolescent to explore different activities, as we were talking before, so that they're not grieving for what's left behind, but they're excited for what they can become. And work with the parents to alleviate anxiety and understand the importance of being active. So give them information to reconceptualize and also to know how important it is to be active first without getting rid of the pain. Provide them with tools to encourage. So look how naturally your body does that. You're doing it just right. Do just the amount of activity that's right for you. Come on, let's do it together. So make an activity fit into life. So re-engage in school and clearly communicate to the wellbeing coordinator or the school support staff about the capacity that the person has, so that they're able to be coached into PE classes. Tips for getting starters: also design your environment. Make sure you got your gear ready. So if the first thing you think you're going to do when you get out of bed is a HIIT class, put your shoes down there and your tracky dacks down there, and make sure that you've got them really close by. So you just get up, get into that, and get going. And make it a micro habit. And you can see here, this is down the bottom is a chart. Micro habits are a really interesting thing. It's just 2 minutes of something. So 2 minutes of lifting weights, or 2 minutes of actually running on the spot. Micro habits compound over time, and then they become, as you change, so your identity changes, as we were talking about before. So I'm a person who does HIIT, or I'm a yogi, or I'm a runner, those sort of things. So you try and ask that and encourage that of the person that you're working with. Habit stacking. So if you're doing something already using neural networks to wake up and shower, then put a post-it note on the shower door and do a yoga pose while the water's warming up. Those kind of tips and tricks will get people back into function before they realise they're doing it. So in summary, for adolescents with chronic pain, the overarching goal is to gain function even before the pain changes. We need an interdisciplinary, coordinated approach and a coordinated sectoral approach. And we optimise return to function requires family-based, psychologically informed and perhaps medication-assisted approach. And these are all the references which we can send out later if you're interested in them. Okay, thanks.
Wonderful. Thank you, Carolyn. That was very cool. And I think, I don't know if all you listening kind of came away with a similar takeaway, but gosh, isn't it interesting how many things movement can affect? Like, I think we all always think about, if I'm moving this, I'm strengthening this, or I'm helping myself get more fit. And well, that certainly can be true. It's amazing to think of the immune, sequelae, the things that happen to sleep, things that help us with our social identity. Like, I think that's a really, really interesting point to take away. So thank you very much. For anyone who might have joined a little bit late, we're going to have all of our speakers go first. So any questions you have for them, put them in the chat and we'll ask at the end. But it is with great pleasure that I introduce our next speaker, Dr. Aleksandra Herman, and she also goes by Ola. She's originally from Poland, and she is a cognitive neuroscientist, and she's currently based here at University of South Australia and SAHMRI as a visiting associate professor as part of a Marie Curie fellowship that she received. And Ola investigates the effects of bodily signals on our behavior and on our decision-making. And she also is interested in exploring the brain mechanisms behind these effects. She studies what happens when body-brain communications malfunction, such as in chronic pain conditions. So Ola, welcome to speak. We do have your presenter view in front of your other screen. So you might just have to, yeah, that's perfect. Now we've got your screen, that's perfect. Welcome.
Great, thanks, Dash. So today I would like to speak about the way chronic pain may affect how we make decisions that involve delay and effort. And this is a very important topic, not only for our daily lives, but also for engagement in treatment for persistent pain. And this is because many treatments for persistent pain involved delayed benefits, such as decreases in pain and improvements in function, that come at shorter-term effortful costs. So, for example, exercise and physical activity in general is often recommended for many chronic pain conditions. This treatment is effective, but the reductions in pain require sustained engagement, often requiring even 3 or 1 months to become effective. And the improvements may also come at short-term effortful costs, such as acute pain and fatigue. And to make matters even worse, the changes often occur gradually, so it's easy to discontinue the routine thinking that it's not really working. So the combination of effortful costs and delayed benefits is not a great one. And this is all because both delay and effort affect how we perceive and value different outcomes. So just to give you a quick example, we have an afternoon now, and I'm not sure about you, but I feel like a cup of coffee and perhaps a slice of cake or other sweet treat. And fortunately, I've learned that there is a piece of cake left in the kitchen. And very luckily for me, the kitchen is just around the corner, so I can just go quickly and grab it at not much effort at all. But what if the kitchen was three floors up and the lift was broken? That would be a substantial effort to get one piece of cake, wouldn't it? What if you had to walk 5 or 7 flights of stairs? Would that be worth it? Perhaps not so much. And this is something very common that affects us every day. The more effort we need to put in to obtain an award, or the longer we have to wait in order to get it, the less valuable the outcome is to us. And this common phenomenon affects each and every one of us, and it's referred to as effort and delay discounting. And this discounting phenomenon may to some extent explain why engagement in treatments involving delay and effortful outcomes is sometimes low. But there also may be another reason. it may be that the experience of pain itself affects how we value the delayed and effortful outcomes. So in other words, the pain may shape how we perceive the world and thus what decisions we make. And it may be that when we experience pain, the immediate and effortless rewards are just much more valued than larger than delayed or effortful ones. In fact, we do know that inducing acute pain in healthy people does just that. When in acute pain, people prefer immediate rewards to more extent than people free of pain. So perhaps this effect could be further increased in people who experience persistent pain. So together with Tasha Stanton, we designed a study to test this idea that chronic pain is associated with changes in preferences towards delayed and effortful outcomes. And for this study, we recruited nearly 400 individuals with persistent pain and a large group of controls who had no history of long-term pain. And amongst many questionnaires, medical history questionnaires, and other questions, we asked them to complete 2 measures of delayed and effort discounting. So the delayed discounting questionnaire assessed the attitudes towards delayed outcomes. Participants were asked a series of hypothetical questions, asking them to choose between receiving a smaller reward available immediately and a larger one available following some delay. So, for example, would you prefer to receive $5 today or $10 in a week's time? The effort discounting questionnaire was similar, but participants made choices between a smaller reward available without any effort and a larger one following an effortful task. For example, would you prefer to get $5 with no effort or $10 after climbing 2 flights of stairs? So what did we find? Actually, we observed quite striking differences between groups, whereby in comparison to the control group, participants with pain were significantly less likely to choose larger delayed gains, as well as larger but effortful gains, meaning that in both cases, they were much more likely to choose smaller rewards. And importantly, these effects were still present when we controlled for various demographic variables such as age, gender, medication use, socioeconomic status, etc., showing that these results seem to be quite robust. So overall, this is some very first evidence to suggest that chronic pain may be related to decision-making processes. However, of course, there are some limitations. And while it is possible that climbing 2 flights of stairs is not a very effortful task for a pain-free individual, it may be a very hard task for someone with pain, which might have influenced our findings. So in our follow-up study, we wanted to adjust that limitation. And we first asked our participants to specify what they themselves would consider an effortful activity to be. They could choose any activity, whether it was walking, running, cleaning, or perhaps doing some gardening. They could also specify duration and time, so it's very individualized. And then we asked them to complete a similar questionnaire that I've just talked about with the activity they chose themselves. And once again, even when we controlled for the individual effort, we found very similar results. Participants with pain, once again, were less likely to choose larger effortful rewards. And again, these differences were still present when we controlled for all the demographic variables, medication use, etc. So in conclusion, I hope that I've persuaded you that our natural cognitive biases and altered attitudes toward delayed and effort and persistent pain may play an important role when it comes to engagement in physical activity and other treatments that involve delayed and effortful outcomes. And I think that addressing those attitudes in clinical practice, as well as in individuals' life, may improve engagement in evidence-based effortful treatments, such as exercise. Which I guess leads us to a very important question of how do we actually do that? Well, I see 2 potential solutions that I think would be quite simple to implement. And one way is what we call episodic future thinking, which is an intervention that has been consistently shown to reduce the degree to which participants discount delayed rewards. And it is nothing else but vividly imagining your future, preferably in a positive way. So, for example, imagine where you might be in 5 years' time, who you might be with, what you would be doing, how you feel, or what you'll be able to do. And following such exercise in laboratory settings, participants are more likely to choose delayed rewards than participants in control group. And there are studies carried out at the moment also to see how it affects people's behavior in daily life, including engagement in exercise. Another way may be instead of fighting our natural preferences for immediate rewards, is actually to go along with them instead. And although I guess it might be difficult to find someone to pay you for doing exercise, there may also be another potentially less costly methods. And actually many fitness apps are already doing that in a way. They often provide points, achievement badges. They often include like friendly competition with other users. And all those forms of little rewards may keep us motivated to keep exercising and provide this immediate gratification. And with that, I would very much like to thank Tasha and Carolyn for completing this journey with me. It has been very challenging. European Union for funding me and getting me all the way to Australia. And I would also like to encourage you that if you find this topic interesting, you may want to consider participating in our online study. Details I'll display on the screen. The more participants we have, the more representative the results and the better solutions we can design later on. Thank you.
Wonderful. Ola, that was a great talk. Thank you so much for sharing that. And gosh, isn't that an interesting idea that, you know, the way that we view what's worth it to us might, that decision-making might actually change. And, you know, who knows, it might be being overprotective of us when we have chronic pain. So an interesting thing to consider. Thank you so much, Ola. Our next speaker is Ms. You are married, but Ms. Erin Macintyre. Erin is a physiotherapist, she's a pain scientist, and she's also a PhD candidate. We're very lucky to have her here with us at the University of South Australia and SAHMRI. And Erin's actually originally from Canada. She's a clinician researcher, and she draws on her experience as a physiotherapist to, you know, help guide and create her research questions. Her current research investigates the links between pain and visual perception, so the way that we see the world around us. And she's also interested in how the latest technology can be harnessed to improve outcomes for people who have persistent pain. So today, Erin's going to talk about how your body feels change what you see. Thanks, Erin.
Thanks, Tash, for the introduction, and thanks, Ola, for setting up this webinar. Here we go. And I am very excited to talk to you about some of my PhD research. And that is really investigating and exploring how your body feels and how that can influence what we see. And I think we work under the assumption that what we see is an accurate representation of the world around us. So we assume and we trust our eyes, we trust what we see, what we hear. But today I'm going to challenge that assumption, and I'm going to maybe convince you that what we see is not always accurate. And that is something that's a little bit strange to think of. And I was definitely in the same boat when I started looking into this research. And, you know, its research does suggest that what we see can actually be influenced by things happening around us, within us, lots of different factors. And that's a bit of a strange concept. But when you think a little bit deeper about it, you actually can start to think of things in your past where actually what you have seen hasn't been accurate. And one example of that I always come back to is this lovely meme. So if you're not familiar, this photo was uploaded to the internet 10 years ago, actually. And it immediately caused a bit of an outrage because people had heated debates. Is this dress blue and black, or is it white and gold? And I still have to say, as someone who sees it very, very vividly as white and gold, I was completely shocked when I saw all these news anchors saying that this dress was blue and black. And I found this absolutely fascinating because everyone was looking at the same image. It wasn't a trick. Everyone was looking at the same image. But while looking at that image, they're seeing drastically different things. So the way that we perceived color was completely different, which is really, really interesting. And of course, researchers also found it interesting. So what they did is they immediately started surveying people. So surveying thousands and thousands of people and showing them this image, asking them what they see, but also asking other things about their lives. And what they found was that their sleep patterns influenced the colors that people saw. So people like myself who see the dress as being white and gold are more likely to be early risers, whereas people who tend to see the dress as blue and black, more likely to be night owls. And what they think is this has to do with your past experiences and past experience of lighting conditions. So people like me who like to get up very early in the morning, we're a bit weird, but we are more likely to see the sun rise and we're more likely to see early morning light. Whereas people who see the dresses blue and black, they're more likely to be exposed to fluorescent light or incandescent light, artificial lights rather than natural light. And what happens is when your brain sees an ambiguous image, like the first image of the dress, it doesn't have a lot of sensory information from that image to pull. So instead, it surveys what it already knows, what its past experiences are, and uses those past experiences to inform what you see. So building on your past experiences, you're either more likely to see as white and gold or blue and black, which is really fascinating. And it's not just memes. It's also a very adaptive phenomena. So we know that these changes are adaptive. It makes sense. Your brain is pulling from past sensory information, past experiences to create a perceptual experience that is most like your past. That's adaptive. We've learned from our past. Other experiments have also highlighted how adaptive these visual shifts can be. So in this study, they had two groups of people, and both of the groups saw a lovely cold glass of water about 10 meters away, and they're asked how far away that glass of water was. One of the groups had just been already force-fed a bit of water, so they weren't thirsty at all, where the other ones were completely parched, so really, really thirsty. And what they found is the people that were thirsty, they viewed that glass of water as being a lot closer to them. So the thing that they needed, that their body needed, was seen as being closer. And the idea is that if you see something as being closer, you're more likely to approach it. You're more likely to think it's feasible to get to that water, which is really quite adaptive. However, if our system is overprotective, then these changes may no longer be adaptive. We may be overprotective and you may have visual shifts that are no longer serving that function and actually becoming overprotective, stopping you from doing the things you want to do. And that to me is really interesting and really relevant for pain. And so for my PhD, I'm exploring the idea that things happening within and around your body can change the way that you see the world, and what factors and what can influence our visual perception. And so I'm going very quickly talk through three different studies that we've looked at this question. And the first one, we want to see answer if your physical capacity can change the way that you see the world. And so for this, there's a theory called the economy of action theory that's very similar to what I've just described with the water, where if people have reduced body capacity, they're more likely to see their world around them as harsher. So they're more likely to see distances as further, hills as steeper. And that can be lots of different changes to your capacity. That can be age-related changes, that can be fatigue, external loads. And we really want to interrogate this theory and survey all of the literature. I started my PhD in 2020, so we weren't doing much in-person data collection. Instead, what we did is we conducted a systematic review. So we spent months reading through and sifting through lots of previous research and taking all of that data and pooling it together. And this review, we included almost 70 articles, and they all evaluated the influence of different types of body capacity on how people perceive their environment, so distances and hill steepness outcomes. And what we found is that there's consistent results that people with less body capacity, so people who are fatigued or older, viewed the world as harsher. However, one thing we didn't look at was how this links behavior. And I think that's the natural next step to this, because we can observe changes in the way people view the world. But unless we link that to behavior, we don't know how important those are. So for my next project, we conducted a second systematic review, this time looking at the influence of threat and on visual perception. And so here, again, we surveyed the literature to see how threat influenced visual perception. So here the idea is that threat should be visually exaggerated. If you're like me and you're terrified of spiders, you're going to see them as kind of looming up. So they're going to be bigger, they're going to be perceived as closer to you, so that they're attention grabbing, so you know to avoid them. And so we looked at how threat influenced that visual perception of those objects, but also we wanted to capture some behavioral outcomes. So we also evaluated perceived action capacity, so people's ability to interact with that threat or move through their environment, as well as behavioral outcomes such as avoidance. And what we found is that threat did alter visual perception. So threats were visually exaggerated. Threatening objects were seen to be bigger and closer to you. There was also some evidence that people experiencing these biases also had produced perceived and actual action abilities. So they were more likely to engage in protective behaviors such as avoidance. However, that's still not too clear, and I think an area for future research. And so moving on to the last study, here we want to see, can pain change the way that you see the world? So pain, of course, encompasses aspects of both body capacity and threat. And so we recruited people with painful knee osteoarthritis to test this. And we chose painful knee osteoarthritis because it really has both elements of, reduced capacity. When you have a sore knee for a long period of time, you have reduced capacity to move within the world. But also there's a lot of threat value, particularly with knee osteoarthritis when it comes to movement. There's often a conceptualization that knee osteoarthritis is associated with wear and tear and damage. And I'm sure Brian will be talking about this more shortly. So we recruit people with knee osteoarthritis and also a group of age and gender matched participants without pain. And we want to compare their performance on some visual perception tests, also in virtual reality. And so what that looked like is we wanted to test hill steepness estimation, because we thought that's quite a relevant thing. It's hard to walk up hills, it's effortful, it's painful, it's often fear-evoking. So we thought that these types of outcomes would be quite relevant. So we had people pop the virtual reality headset on, and then once they're in that virtual environment, they saw a bunch of hills, and we asked them how steep each hill was. And what we found is that indeed people with knee osteoarthritis overestimated both uphill and downhill steepness compared to people without pain. So you can see here on these graphs, the knee osteoarthritis group, that's your dark blue group, and they had greater overestimation for both uphills and then downhills as well. So people with knee osteoarthritis viewed the world as harsher. We also wanted to see how that correlated with different clinical outcomes, in particular fear and physical activity. And what we found was very strong relationships between hill steepness errors and state fear, so the fear people were experiencing while looking at that hill. So as you can see on the left here, that was a really strong relationship where people who overestimate hill steepness were also far more likely to be afraid of moving and interacting with that hill. We also found weak correlations and marginally significant correlations between step count and perceptual overestimation. And so here, people who did fewer steps in the week leading up to testing had greater perceptual overestimation. And this is a weak correlation, but I think that actually makes sense when we think about what Dr. Herman's just talked about and what Brian's going to talk about shortly. There's lots and lots of things that go into making a decision about whether you're going to move or not. And something like a perceptual bias is probably one of many, many factors that influence these decisions. So I think that's actually probably quite accurate. And so all in all, first of all, some takeaways. I think it's important to remember that perception is complicated. Lots of things that we're aware of, that we're not even aware of, can influence how we see the world around us. So going back to the dress, I was not aware of how my sleep habits could possibly influence how I saw color, but they did influence it. And even though I specifically know that information now, I can't actually shift that perception. So these unconscious processes play a really powerful role in our visual perception. And that these shifts in visual perception may actually change our behavior, which again is generally adaptive. However, it may become maladaptive when our system becomes overprotective. And so what does this mean for you? I think it's really cool because it opens up new treatment options. And that's what really makes me excited about this research, is that it's exploring new implicit barriers to movement and to exercise. And so a few things that I think are really exciting is, first of all, thinking about perceptual retraining programs. So if we try to change the way that people view the world by explicitly training this kind of this bias, can we reduce barriers to exercise? Can we make it easier for people to start moving again? And also, Tasha mentioned my love for virtual reality, and same with Carolyn earlier. Can we use new technology such as virtual reality to start to shift our perceived body capacity and then in turn perception? So if we have a virtual reality program where you get to be, Superman or the Hulk, you get to be something, a really, really strong character, can that actually shift the way that you see the world for the better? Does that make the world feel less harsh? Does it feel more achievable to get moving? And I think that's really exciting and something that I want to explore further. So thank you very much. And I'm excited for the rest of the presentations and for the Q&A.
Thank you so much, Erin. I have to say, I don't know about you guys, but that snake looked enormous to me. But I love that delve into this idea that, yeah, we might be as human individuals more complex than we might realize, although I think we start to appreciate our complexity, but even that the way that we see the world and this sensory perception for something that is as reliable as vision still has these potential shifts that might hold relevance to us in terms of when we have pain and when we undergo treatment. Thank you so much, Erin. Our last but not least speaker of today is Dr. Brian Pulling, and I get to say Dr. Brian Pulling for the first time because he's recently completed his PhD with us here at the University of South Australia and SAHMRI in the area of health-related conceptual change. Currently at the moment, he's working as an epidemiologist and a research associate at another group here at SAHMRI called ROSA, or Registry of Older South Australians. And he's also working as a course coordinator in pain sciences for a variety of health and research related courses at UniSA, where he also does tutoring and facilitation. So his research interests lie particularly in how we teach and we learn about health, including pain. So Brian, I'll turn the floor over to you.
All right. Screen there. Come on. There we go. So I actually, I want to start off by asking all of you a question. And I can see you all nodding and thinking curiously, but I want to know, what do you think about pain and activity? My work has really focused on this big, beautiful field called psychometrics, which is, put simply, the idea of how do we measure what people think? And that's what I'm going to talk about today. This is me and Tash, me trying to make Tash laugh during a photo shoot. I'm not sure why they asked me to do the photos for the UniSA marketing department, but there you go. Like Tash said, I've done my training here at UniSA and I work at SAHMRI, and my PhD research was funded by a scholarship from Arthritis Australia and an NHMRC project grant. I've tried to live by this motto. I don't know where it comes from, but I really enjoy the thought that you can't improve what you don't measure. And all of our work tries to result in better treatments, better outcomes for people with pain. This is me presenting some of this work a few weeks ago in Darwin. You're probably familiar with this. This is one of many pain scales where you rate your pain on a scale from 0 to 10. 0 is no pain and 10 is the worst possible pain you can imagine. This is an old idea. There's nothing new about this. And actually, there's a lot of complicated research and statistics that goes into developing good quality measures for how people think about complex subjects like pain. But if you've ever had to fill one of these out or respond to, a GP or maybe a physio about rating your pain, that might have left you dissatisfied. It certainly leaves me dissatisfied because pain is a lot more complex than just a number from 0 to 10. But unfortunately, that's the main way that we assess people's pain, is through its intensity. There's another quote that's really stuck with me that, again, I can't attribute to anyone, but it's that measuring pain purely in terms of its intensity is like trying to describe music only in terms of its volume. It's certainly very important, but it leaves out a lot of really important nuance. So that was the question. How do we capture that nuance? We're trying to study people with osteoarthritis, painful knee osteoarthritis, so that we can help them get moving. We know that movement is important for osteoarthritis, but people aren't moving enough. So let's try to evaluate why that might be. What do you think about pain and physical activity? We know that an individual's beliefs about their health can impact their treatment choices. We also know that misconceptions may lead to an avoidance of evidence-based care. And really, this just comes down to the idea that why on earth would you participate in any kind of treatment if you didn't think it was going to be helpful? But some treatments like physical activity have been shown to be quite helpful despite the prevalence or the commonness of beliefs that it wouldn't be. We also know that assessment of the ways we think about health broadly, irrespective of the topic, is very complicated. So today I thought we should talk about statistics. How's that sound for everybody? This is a very frightening image. I went to ChatGPT and tried to get the most frightening image of wear and tear that I could find. So this is an illustration. It's not real. This is not what your knee really looks like, but it might be what your knee feels like if you have painful knee osteoarthritis. And I just said that idea of wear and tear. This is a very common idea. People often describe their knee pain as being caused by wear and tear. But wear and tear can be thought of in a few different ways. What about the wear and tear on a beloved book that you've just worn down the pages from so many lovely reads? Thank you again to ChatGPT for this one. So we wanted to try to evaluate the complexity of people's beliefs around these complex topics related to their osteoarthritis, physical activity, pain, and not just one thing, not just one number like their pain intensity. That's a complicated undertaking. And I'd love to spend this whole session explaining to you how methodologically we go about developing a questionnaire like the one that we developed, the Osteoarthritis Conceptualization Questionnaire, or the OACQ for short. But it's a bit wordy and not that interesting. Basically, it's a three-phase process that starts with item development here on the left, moves through to scale development and scale validation. And each of these requires different statistical methods and surveying approaches. And I've got the links for these if you're interested in finding out more. This Baotang paper from 2018 goes into a lot of depth. If you're interested in scale development methods, please send me an email. It's really interesting. But, oh, this is the first of those papers. The others are still under review with different journals. But I want to focus in for a moment on scale development. This is a really critical idea where we've asked a lot of different people to fill out our new questionnaire. So it's not validated yet. We're still trying to understand how it works a little bit better. And there are different statistical approaches that we might take to evaluate it. These are two psychometric models. And if they look a little frightening, don't worry. I just want to talk big picture about the theory that underpins these ideas. So you'll leave today with a little bit of background on psychometric theory. On the left here, we have factor analysis. Factor analysis is really the key historical underpinning of psychometrics. In 1904, Charles Spearman wanted to quantify intelligence. He wanted to know exactly, to a number, how smart a person is. And that's how we got IQ tests today. Each of these little square boxes is an observable variable. It's a question. It's a questionnaire or a test item that you can answer on a piece of paper. The big circles are latent or unobservable constructs. They're things we can't see, but we think might exist in a person's mind. So Charles Spearman thought that intelligence was one of these latent constructs. You can't ask one question that sums up a person's intelligence, but you can ask many questions that start to point to the big picture idea of their intelligence. The little circles are statistical variants. We don't need to worry so much about those right now. This is a lovely statistical model. It makes a lot of sense and it can be really useful across the spectrum, all the way from educational theory, where university professors are developing tests for their students. And then on the other hand, it can be really useful in health when you're sitting in the doctor's office at the GP or the physio and filling out yet another form about your knowledge or your beliefs or your experience or your anxiety or your depression, things like that. It can be really helpful, but it has one important limitation. And it's that those big circles, those latent, unobservable constructs exist in the first place. We can't prove it. They're unobservable. That's the whole point. We can't say for sure that IQ is one thing, or even from the health perspective, that something like depression is one thing. It could be made up of many, many things. And so we can use a questionnaire to evaluate the symptoms of depression, but we can't definitely quantify the one thing of depression. And in comes network analysis. So where factor analysis is 120 years old, network analysis is about 6 years old, at least in the context of health. Network analysis says, yeah, we can't know for sure that the latent or unobservable thing exists at all. But we can ask lots of questions and see how those questions relate to one another. And that can be really useful. So here we see all of the squares and the little circles pointing to one another directly. And we look for the statistical relationships between the questions themselves. And yeah, maybe they target some underpinning idea. But if they don't, that's okay too, because they still relate to one another. We'll see why that's important in a minute. This is our questionnaire. It's a 36-item questionnaire. There are 5 response items for each question. So you can say that you strongly disagree, you disagree, you neither agree nor disagree, you agree, or you strongly agree, 1 to 5 on a 36-item questionnaire. So the max score is 180. So if you get a perfect score, you get 180. And that's a lovely idea. But the problem there is the variation, because 2 people can fill out the questionnaire in exactly the same way, except for one question. They can change their answers for 1 or 2 questions and still get the same total score, but have different responses on individual questions. So if we look at the total number of possible responses to this questionnaire, I did the math and I had to write it down. It's 1.46 times 10 to the 27. And I have no idea what that is. So I asked ChatGPT again, and ChatGPT says it's 146 septillion. And I have no idea what that is. So I asked ChatGPT how many grains of sand there are on Earth. And it told me that there are 7 quintillion, 5 quadrillion grains of sand, and that is still significantly less than the number of possible responses to my questionnaire. So I'd say that's pretty good work for a PhD. Really what I'm getting at here is there's a lot of variability, and we don't want to just create another sum score. Yeah, you can rate your pain out of 0 to 10, and yeah, you can answer the osteoarthritis conceptualization questionnaire from 0, or it's technically from 36 to 180. But that's still one number trying to summarize the whole of your experience with osteoarthritis and pain and physical activity. These are big ideas. Now, we are able to separate them out because of all those other analyses that I talked about into 4 key domains. I'll talk about that in a little bit. But let's put a pause on this and come back to some of the individual questions on this questionnaire. We looked at a few of the different questions. So one of the questions is, physical activity and exercise is good for my osteoarthritis, no matter how severe my osteoarthritis is. And so you can say whether you disagree or agree with that statement. Another question is, exercise will do more harm than good because I have osteoarthritis. And again, you can strongly disagree or strongly agree with this statement. And you can see how these statements differ. Now, I looked to see how many people agreed with both of these statements. It's only about 8%, which makes sense because these are sort of opposites. One statement says physical activity and exercise is good, and one says not so good. So agreeing with both would be a misconception or a synthetic conception. Here's another pairing. The same first question, physical activity and exercise is good no matter how severe the osteoarthritis is, and exercising wears out my knee joint. Again, sort of opposites. So we wouldn't necessarily expect high agreement between both of these statements. And again, about 8% of people agreed with both of these statements. So not that many people have the misconception for both of these statements. Let's look at one more. Wear and tear is an accurate descriptor of my osteoarthritis. Remember, I mentioned that at the beginning. This is a very common sentiment among people with osteoarthritis. And here's this other statement again, physical activity and exercise is good for my osteoarthritis. 41% of people agreed with both of these statements. That surprised me. I don't know about you. And I'm sure if you have osteoarthritis or pain, you're probably thinking about how you would answer both of these questions. But this was a large sample. This was around 450 people answering this questionnaire. And that's a lot to agree to both of these statements. Now, explicit questionnaires are one part of the picture. I'll talk more about this one in a minute. But first, I want to talk about this idea of the implicit test. So we've talked about explicit questionnaires, explicit assessments, or when you fill out a questionnaire on a piece of paper. But implicit association tests look at what we unconsciously believe about that particular construct. And you might have heard of Project Implicit. They've developed these for things like racial bias, gender biases, political biases, disability or age biases. And they're free. You can take them online. They're kind of fun. Interesting to see how we unconsciously think about these ideas and maybe whether our unconscious beliefs differ from our explicit beliefs. So we made one. During my PhD, we made an implicit association test. This is what it looks like. So you have to categorize words and pictures into different categories. So this one, do you think this is a picture of someone being active or someone at rest? Most people think it's someone being active. And so they would categorize it to the active side. Here's another one, but we made it a little more complicated now. So is this person active or in danger and safe or resting or safe? And this one we'd say probably is rest and safe. Now, I did this very slowly. When you actually do an implicit association test, you have to categorize these stimuli very, very quickly so that it's an unconscious response. And that's important for a lot of statistical reasons, but mainly it removes response bias, where you're trying to give the right answer. You can't give the right answer. You're giving the answer that goes with your gut, deep in your belly. And we published it And we found that people with painful knee osteoarthritis hold a negative implicit attitude toward activity. This is what it looks like. And you can see that people in purple here with knee pain have a much higher, they call it a D score, but it's a bias that activity might be dangerous than people without pain, or even people with non-knee pain. That's interesting. We're going to follow up on that in future research. So we know that explicit assessment is only one part of the picture. But that brings us back to the key question, which is, what do you think about pain and activity? All of these questionnaires, all of these different assessment methods are meant to help researchers or clinicians better understand their patients quickly, efficiently, but in a way that's comprehensive and not losing that important nuance. So quality development of these assessments takes a long time. That's why I spent a whole PhD on it. And it takes a lot of effort from people with pain or from people with that lived experience to fill out all of these different surveys. So if you might have actually heard of some of these already, and I appreciate if you have, I want to circle back and talk about the questionnaire, because we think the questionnaire might fit into a clinical process. I'm going to circle two of the questions. Each of the dots on the screen is a question, and the lines between them are the relationships, the statistical relationships between the different questionnaire items. So over there on the right, question 20 is about wear and tear. It's that wear and tear question. And over here on the left, question 10 is that physical activity is good question. These are on opposite sides of the network. So they're not very closely related, which might be why we saw such high agreement between these two potentially unrelated concepts. It's a misconception that wear and tear is accurate while also physical activity being good. If physical activity causes wear and tear, then how can physical activity be a good thing? And this is why we're trying to better understand people's misconceptions about physical activity and osteoarthritis so that we can help them engage with the best practice treatments for their condition, namely physical activity. And targeting specific beliefs rather than just an overall sum score on a questionnaire could be one way to do that. So we can look for important questions on this questionnaire, like this one, this tricky number 8 here, circled in blue. Question number 8 is that the osteoarthritis in my joint can improve without surgery. Now, this is interesting. This surprised me, but it might be that this question could be a useful target for treatment because it's more in the center of the network, which means it has stronger connections, statistically speaking, to more of the questions around it. Whereas the wear and tear question and the physical activity is good question are sort of at the periphery. They're not very well related to most of the other questions in the questionnaire. And then we have our 4 domains, looking at maybe rather than the overall questionnaire, but domain-specific items in the questionnaire could be helpful. So we have questions about the influence of variables on osteoarthritis, the physiology of the condition, a person's expectations for their condition, and the idea of conceptual change or learning as being important for the condition. So going back to this question of what's next is about figuring out how these different questionnaires, these different assessment tools relate to one another, and most importantly, to the clinical outcomes, like a person's pain over the long term and their physical activity over the long term. So I'll leave it there. Feel free to reach out if you have any questions or ideas. Thanks so much for listening.
Thanks, Brian. I think probably a takeaway from a lot of these is the complexity with which we bring ourselves to a situation and how that influences how we move. And I think I've always been really intrigued by that implicit association test that Brian was speaking about, the fact that it actually, captures new information that we don't capture by questionnaires. And that can be really important in helping to target people who, might need a little bit of extra in terms of intervention. So I'm going to turn us over to some of the questions. Thank you so much for putting these through. I had the first question. I'm just going to pull this up. I'm going to keep chat up and questions. I think we've used a little bit of both. The first one we have is for Carolyn. Just wondering, thanks for your presentation. Just wondering in regards to adults, is there any evidence that you are aware of to suggest that being a good social sports person, so adults that play regular sport with their mates for fun, being a social sports person acts as a protective factor to the development of chronic musculoskeletal pain?
I would have to say that I don't know of any of that research that's been done. I'd be happy to hear if anyone else has come across that. I could imagine that it would be a very interesting thing to research itself. And yeah, I don't know. I
Yeah, so
think
Darren had a bit of a hypothesis that he was saying, unfortunately, my guess is that belief in society is that it makes people more prone. And I think we certainly see that in terms of osteoarthritis, where it's like, oh, if you played this sport, you're definitely going to have bad knees, and so it does speak, doesn't it, to some of the societal beliefs that we hold in this area. How have you found, I guess, some of the beliefs, you touched on this in your presentation a little bit, but beliefs surrounding kids' pain or adolescents' pain?
I mean, it does come back to what Darren's hypothesis is that, let's not do that movement because that will be hurtful or that will be damaging. And parents are certainly, so the adult component of that is certainly protective, wrap them up in cotton wool. And it takes a while to break down some of those barriers or some of those social beliefs, I think. But yeah, I don't know. We haven't, when we're working with parents, we're sort of trying to get them all on the same page. And we do use a lot of the outcomes of exercise or the outcomes of activity. So that slide that you saw where sleep and, various different factors that play into the chronic pain experience for the adolescent, we use all of that. And so hopefully the adult will actually take away a little bit more about how much exercise helps various different systems in your body rather than focus on, the detrimental side of it. But yes, it's an interesting question. It's really a good question. Thanks, Darren.
Yeah, I think you're so right, Carolyn. Like when you think about if exercise is, you're viewing it as creating more of the problem, if we probably view it from a very biomechanical lens of like it's just being hard on that part of the body, but we don't see those larger aspects of like immune and sleep and things that you bring up, we start to have new hypotheses why exercise might work or be helpful. Thank you, Carolyn. Oh, I've got a good question. This is from Margaret Knight. Oh, it's a ripper, and this is for you, Erin. So I do think it's a great question. How is threat estimation influenced by circumstance? I'm deadly afraid of snakes, but if my pet was in danger, I would rescue it.
That is an absolutely fantastic question. I love that. And I think my answer is it's complex. And when we think about these perceptual biases, it's not just the value of the object, but also your internal motivations that really drive these effects. So we can actually, if we unpack it, we actually see that we have a similar perceptual bias with two drastically different circumstances. So if we are desiring something like a cold glass of water, we tend to see it as closer. And also if we're threatened by something like a snake, we see it as closer. So that rather than thinking of it as the value of that object itself, it's more about our motivation and how we are responding and whether we think it's our best in our best interest to approach or avoid that object itself. So I certainly think if I'd be the exact same in that situation, I love my dog, and even if I saw a snake that's big and threatening, that would probably be overridden by my motivation to rescue my lovely little pupper. So I would definitely be, potentially experiencing that bias, but also potentially, having a similar bias where my dog is big and close to me and I'm going to go and run out and grab her. So I think if you break it down towards your motivation and what you want to get out of that situation, that's probably the best way to think about it.
Yeah. Thanks, Erin. And I think it actually leads in really lovely to some of Ola's work in terms of that kind of cost benefit of a different situation in terms of the effort that you put in, because all of a sudden that cost benefit ratio shifts. Ola, I have a great question, or more of a comment actually in the chat, but do you think that, so a lot of times, I think particularly when a person is first, starting to cope and figure out how to live life with a persistent pain condition, there can be a focus on, I've got to find, that magic bullet fix. There's something that is just the one thing that needs to change. Do you think that holds relevance in terms of kind of your cost benefit or cost effort decision making? Do you think that might explain sometimes why we're looking for that, I guess, immediate reward?
I guess in a way we are all prone to, to have this immediate reward, to have something effortlessly, quickly, painlessly, and obviously this is not always the case. So I think this again speaks to our natural tendencies and biases that were developed to protect us in a very different environment, and obviously at the moment in a current civilization, they may not actually be so protective and useful anymore. But I guess that how I think about it is that it's very important to actually learn about those biases, because only by becoming aware of them we are able to do something about them. So perhaps by learning about them, we are also better able to create more, like to be more creative about finding solutions, and perhaps finding that one way easy fix, but it may not be the obvious one.
Love it. Yeah, thank you. That's a great answer to that. We had one question that is, I think, a bit technical, and I believe it was directed at you, Carolyn. But when you were discussing with adolescents, you were using different virtual reality programs to help engage with movement and activity. Can you comment a little bit on which virtual reality programs you were using?
Yeah, sure. Very simple ones like Beat Saber and Fruit Ninja. Both of those work really well. And also there's Stanford have a specific place called InvinciKids who make specific VR programs, which we're using just on the Oculus Rift. So it's pretty easy to get access to them. And they just require, so if you're interested in actually using the just movement programs, putting people into different scenarios of transport or just different worlds and things like that, they're really great. They have quite a number of those programs, and they just require you to sign up with a contract. At the moment they're free, so it's a good thing. So maybe you want to have a look at InvinciKids on the website as well and see whether they offer anything. But honestly, there are lots of very easily attainable active VR programs out there. We have used different, so for example, there's a fellow who got burnt, and we were using an ice world with him, which has got some evidence behind it to actually say that you're going to improve, and he was really keen to do skiing, so we got him on the ski slopes on VR, just one of the normal programs, and that has helped him amazingly. So often it's good to think about the context in which they're experiencing, or they experienced the injury or the pain, and what they really love doing, and then you can choose something that's from the normal process there, all gets going. But yeah.
Thank you. So I love that fact that a lot of these are free at the moment. So it means that as soon as you have a head-mounted display or the VR goggles that are compatible with some of these, then you can download them, use them, which I think that's so nice to do, because we, as Erin well knows, when we try to sometimes make custom ones, it can be quite challenging. Brian, perhaps a question for you. You spoke about some of the kind of scientific psychometrics behind some of these questionnaires and tests, and where you might want that to go from a scientific perspective. But from a clinical perspective, where might you see value, for example, of using an implicit association task where we get people's, unconscious ideas or beliefs about the danger or safety of activity? Where might you see that be useful in a clinical encounter?
That's a great question. Intuitively, actually speaking to Ola's comment a moment ago, I think it can be helpful to I think it can be helpful to be aware of our, I don't know if I'd go as far as to say bias in this context, but our awareness of the potential unconscious threat associated with activity. So if a person thinks unconsciously that activity may be threatening and rest is more safe, that might help them explain some of their interest or aversion to physical activity. We haven't tested that, and that's really an interest of mine from a research perspective to see, well, are implicit beliefs about threat and activity changeable? Can we target these through treatment? Can we have discussions in, physio clinics about, well, why might these implicit beliefs have come about, and how could they change? That really interests me. I also think it could be useful to know about the whether an implicit association test relates to other types of tests or measures. So looking at the relationship between the implicit association test and, for example, physical activity. Perhaps we think maybe that this implicit association test could be predictive of a person's either willingness to participate in physical activity or just their baseline level of physical activity. And so that's something that we should continue to investigate. But we've also seen already that the implicit association test does not always relate well to existing available measures that are explicitly reported. So things like traditional questionnaires. So a person might say that they are not afraid explicitly. They might say they're not afraid of physical activity. And yet, when they do the implicit test, we don't see that same report. We see that actually they do find physical activity to be threatening. So at a minimum, I would say that right now it gives clinicians information that maybe they could use to target in treatment. And that's our real question, is in future research to try to formalize that approach.
Beautiful. Well, I think in the interest of time, I'll probably wrap things up here. Thank you all for attending. And I think I thank you all to the speakers. You did an excellent job today. And I love this idea. First of all, I think of the very practical strategies, such as, can we create micro habits? That's so helpful, Carolyn. I love that terminology. And then also for others, the way that we can appreciate, I think, the complexity of our decisions and our experiences and what might underlie us choosing to move. Because I think traditionally that's really been thought to only relate to, oh, if they're not moving, they're not motivated. And I think we're here kind of saying that's a bit of rubbish, and that there's a lot of things that contribute, some of the things that you might not even be aware of. And that's, I guess, what some of our group is really trying to understand. So I hope everyone has had a wonderful time. It has been recorded, as I said. We will make sure speakers are happy for it to be shared, and then we can make it available. So thank you all for attending. Have a great afternoon.